Hello, a very good afternoon to all our viewers. Welcome to this brand new episode of MasterSeries session. We're going to talk about transplant and pulmonary hypertension. And for this, we have two experts here with us today. Please welcome Dr. Basha Khan, welcome sir, and Dr. Prashant Bobhate.
Good afternoon, and please accept our sincere gratitude for providing us this platform to share our insights about this complex disease.
Thank you so much. So something about our speakers for today. So Dr. Basha Khan is a senior consultant in transplant, also the medical director of lung transplant at Narayana Health in Bangalore. He has a vast experience in the field of lung transplant, respiratory critical care, and pulmonary hypertension specifically. He holds the memberships and certifications in ERS, ISH, LD, etc. And Dr. Khan's area of interest include respiratory failure and CF, ECMO, EBUS. We are pleased to have you with us here, sir, and also to help us plan this session. Thank you so much. Our second speaker is Dr. Prashant Bobhate, who's a consultant pediatric cardiologist at Children's Heart Center at KDAH, Mumbai. He has over 12 years of experience in non-invasive and invasive pediatric cardiology procedures, 2D, 3D echocardiogram, transesophageal echocardiograms, diagnostic cardiac catheterization, etc. His areas of interest include diagnosing and treating children with, of course, congenital heart disease, but also pulmonary hypertension and fetal echocardiograms. So first we'll have Dr. Prashant, who will be talking about pulmonary hypertension, and then we'll have Dr. Khan to join us here to speak about transplant in pulmonary hypertension. So without further ado, I would invite Dr. Bobhate to start the session, please.
Yeah, thank you, Darshika. Thanks for the lovely introduction. I'll just share my slides. Okay. Can you see my slides now? Yeah. Okay. So good afternoon, everybody. First of all, I would like to thank the organizers as well as Doc Plexus to give us an opportunity to share our thoughts about pulmonary hypertension. It's a rare and a complex disease, and we hope that we'll be able to do justice to the same. So I would be talking about what is pulmonary hypertension, what is definition of pulmonary hypertension. I would talk in brief about clinical features of pulmonary hypertension, evaluation of patients with PH, what do the guidelines say, how do we manage pulmonary arterial hypertension, and maybe some cases to highlight the importance of evaluation and management of pulmonary hypertension. So the first World Symposium of PH was held in 1973 in Geneva, in which the mean PA pressure was defined as, pulmonary hypertension was defined as mean PA pressure was more than or equal to 25 as measured by right heart cath. However, the value of 25 was arbitrary and did not address various pathophysiology such as which could result in increase in PA pressure, such as precapillary, postcapillary, or combination of the both. And this definition has by and large undergone a lot of changes over the last 25-30 years. And the latest definition which was given is in 2018. But before we do that, there was a paper which was published in European Respiratory Journal 2009, which looked at what was the actual normal PA pressures. So they found that even if you take +3 standard deviations, the systolic PA pressure is not more than 34 millimeters of mercury, and the mean PA pressure is not more than 20 millimeters of mercury. That is +3 standard deviations from the mean. And the normal PVRI was 0.9 to 0.4. Plus minus 0.4 Woods units per meter square. And this was true across ages beyond 3 months of age. As we all know, neonates and children have a slightly higher pressure and they undergo neonatal transition. And once that happens, then the normal PA pressure is what actually is with the adult population. So the recent definition was given in 2018 in Nice World Symposium, and which defines pH as a mean PA pressure of more than 20 millimeters of mercury based on the previous study which I had quoted. They also kind of separated precapillary, postcapillary, and a combined pre and postcapillary pulmonary hypertension. So precapillary pulmonary hypertension is defined as mean PA pressure of more than 20 with a PA wedge of less than 15 and PVRI of more than 3 Woods units. The post-capillary pulmonary hypertension, in which it was the mean PA pressure is more than 20 with the PA wedge pressure more than 15 and pulmonary vascular resistance of 3 Woods units. So as we all know, pre-capillary pulmonary hypertension is pulmonary arterial hypertension, and post-capillary pulmonary hypertension is pulmonary venous hypertension. And that is mostly because of the left heart disease. So LV dysfunction, mitral regurgitation, or some congenital heart diseases such as aortic stenosis, mitral stenosis. These all can cause increase in the left atrial pressure, which increase the pulmonary venous pressures, and they subsequently increase the pulmonary artery pressure. So that is what we call as a post-capillary pulmonary hypertension. If you have a pre-capillary phenomenon such as pulmonary arterial hypertension, in which the PA wedge pressure or the LVEDP is always less than 15 millimeters of mercury. Now, what happens if a patient has got left ventricular dysfunction? He initially starts to have increase in the LA pressure, increase in the pulmonary venous pressures, which consequently increase in the pulmonary artery pressure. So this is pure post-capillary pulmonary hypertension. But eventually, over time, what happens is there is constriction of the pulmonary arteries, and then there is what we call as a combined pre and post-capillary pulmonary hypertension, in which the mean PA pressure is always more than 20, the PA wedge is more than 15, and the PVRI is more than or equal to 3 Woods units per meter square. So after having gone through the definition, we'll look at what are the clinical features of pulmonary hypertension. Now, pulmonary hypertension is a disease in which the clinical features are not very, they're usually subtle to begin with until the patient develops a right heart failure. So the common clinical features of pulmonary hypertension are easy fatigue, tiredness, not able to climb up stairs. Sometimes the patient has a syncopal episode. And then eventually when the right heart fails, they have features of the right heart failure. Because of this subtle features of pulmonary hypertension, the initial features of pulmonary hypertension, and because most of the patients are females who are in their 20s and 30s, they frequently get misdiagnosed at some other diseases until actually frank right heart failure develops. On an average, and this is true not only in India but even the Western world, on an average there is a delay of approximately 2.5 to 3 years between onset of symptoms and actual diagnosis of pulmonary hypertension. And the more early we suspect and diagnose pulmonary hypertension, the better is the treatment protocol for these patients. So as I said, they're usually young females in their second or third decades of life. Symptoms are usually non-significant, non-specific, such as easy fatigue, palpitations. And in advanced patients, they may have syncope, pre-syncope, edema, ascites, and eventually right heart failure, right? So it's very important for us to suspect this kind of diseases when the patient has got early symptoms. And as I said, there's an average delay of approximately 2 to 4 years from the onset of diagnosis and the treatment. Now, once we have diagnosed pulmonary hypertension, so if you have these kind of patients, at least do an ECG, electrocardiogram, to see what is the right ventricular forces, if they can be seen on ECG. So if you have this kind of patients, get an ECG, see if there is a right atrial enlargement, right ventricular enlargement, right axis deviation, and of course, if there is right ventricular hypertrophy with strain. And if you have any doubt, please get an echocardiogram done. An echocardiogram is a very good screening test to look at to diagnose pulmonary hypertension, at least to diagnose pulmonary hypertension. And once we have diagnosed pulmonary hypertension, there are two very, very important aspects about management of pulmonary hypertension. One is search for etiology, and second is risk stratification with incremental medical therapy and intervention. So both of these are extremely, extremely important. So how do I search for etiology in a patient once I've diagnosed pulmonary hypertension? So as I said, once you have signs and symptoms which are suggestive of pulmonary hypertension, we do non-invasive assessment, which is to suggest if there is PH or no. And for this non-invasive assessment, we'll do an electrocardiogram and an echocardiogram. Now, in this, if we find that there is some evidence of pulmonary hypertension, we usually refer it to a specific PH center who cares specifically for pulmonary hypertension. And in this, we consider most common causes of pulmonary hypertension. So the most common causes of pulmonary hypertension, even in India, are left heart disease and group 3 or lung disease. So if you have a left heart disease or a lung disease or hypoxia, these are the most common causes of pulmonary hypertension. And once we see a patient of pulmonary hypertension, it is first required for us to rule these out. So rule out a left heart disease and a group 3 lung disease or hypoxia, which can cause pulmonary hypertension. Okay, now once if we have diagnosed as group 2 or group 3 pulmonary hypertension, then we treat the patient according to what is the underlying disease. So COPD, you have to treat COPD, left heart disease, you have to treat left heart disease. Now, if you don't find that the patient has any evidence of left heart disease or lung disease, the next step is going to do a VQ scan to rule out thromboembolic pulmonary hypertension. In the current scenario, we can also do a CT pulmonary angiogram, a high resolution CT pulmonary angiogram, which will kind of rule out chronic thromboembolic pulmonary hypertension. So if on the CT scan or a VQ scan, if you see some segmental defects, then it goes into thromboembolic pulmonary hypertension or group 4 pulmonary hypertension. If there are no segmental defects, then we consider other uncommon causes of pulmonary arterial hypertension. But before that, we have to do what we know as right heart catheterization, because as we know, echo is just a screening tool. The diagnosis is confirmed by doing a right heart catheterization. And by doing a right heart catheterization, we see that the mean PA pressure is more than 25 or 20 millimeters of mercury, depending upon the current definition, and the pulmonary wedge pressure is less than 15 millimeters of mercury. So once we do that, once we diagnose that, we specifically get to know that this patient has group 1 pulmonary hypertension, or what we commonly call as pulmonary arterial hypertension. And once we do that during the right heart catheterization, we also do a inhaled nitric oxide, or what we call as a vasodilator testing. We give the patient inhaled nitric oxide and see if the PA pressures decrease or don't decrease. Now, after the right heart catheterization, we do a whole lot of tests to try to find if there is any cause of pulmonary hypertension, and extremely important. So we look for pulmonary veno-occlusive disease, chronic thromboembolic PH, history of drugs and toxins, HIV, other viral infections. If there is any congenital heart disease, portopulmonary hypertension is another common cause of pulmonary hypertension. So ultrasound abdomen and a CT abdomen may also be helped. If there is history of chronic hemolysis such as thalassemia, sickle cell anemia, all these also can cause pulmonary hypertension. Schistosomiasis can also cause pulmonary hypertension, although it is rare in our country. If nothing is there, then we are left with what we call as a dustbin diagnosis or idiopathic pulmonary arterial hypertension. But unless we do all these tests, we are not supposed to call the patient idiopathic pulmonary hypertension. And before even calling idiopathic pulmonary hypertension, we have to do a genetic testing, which is the whole exome testing, which is easily available in the country as of now. And if the whole exome testing is positive, then he goes into heritable PH. If the whole exome testing is negative, then the patient has got what we call as a truly idiopathic pulmonary arterial hypertension. So what is the importance of etiological assessment? I'll just go through a couple of cases. So we had a 16-year-old female who came with easy fatigue syncope, was diagnosed with pulmonary hypertension 4 years back, and was started on sildenafil and tadalafil and ambrisentan. She initially responded, but had gradual decrease in exercise capacity and was actually billed in a clinic. She was not able to even walk. So here see, the patient was on echocardiogram, somebody suspected pulmonary hypertension, and they forgo all the steps and directly call the patient as idiopathic pulmonary hypertension. On further inquiry, you can see that the patient had got small joint pains and a red-on phenomenon. And on investigation, the ANA and dsDNA was positive. She was diagnosed as SLE, was started on steroids, HCQ, and methotrexate. She walked into our clinic after 3 weeks with a 6-minute walk test of approximately 20 meters, and echo which was suggestive of improved right heart function. So the diagnosis was CTD-PH, and she was misdiagnosed as idiopathic pulmonary hypertension. We have another patient who was an 18-year-old female who was symptomatic since last 2.5 years, was treated and diagnosed as pulmonary hypertension with marginal or no response to pulmonary vasodilators. Again, the diagnosis of idiopathic pulmonary hypertension was made just based on echocardiogram. We did a VQ scan, and you can see there are a lot of perfusion defects which are seen in the VQ scan. A CT scan was repeated, and you can see that there are clots which are there in the pulmonary artery, in the main pulmonary artery, as well as the distal pulmonary artery. So this patient had thromboembolic pulmonary hypertension. She underwent an endarterectomy, and these are the clots which are removed from her lung parenchyma. Her mean PA pressure at discharge was just 22 millimeters of mercury, and now she is at a follow-up with us for more than 1 year and continues to be in function class 2, and she's not on any pulmonary vasodilator. She's just on anticoagulation for her factor V Leading deficiency. After this etiological assessment, we come to what is called as a risk stratification. Now, why is risk stratification important, and why do we need risk stratification? It is important for us to guide management. Now, if you see the guidelines, we first have to find out whether the patient is in low risk category or a higher risk category. Because if the patient in low risk category, it is usually treated with oral medication. It is also used to monitor treatment response by serial assessment every 3 monthly or 6 monthly, establish prognosis and predict mortality. So what do we use to do the risk stratification? In the previous years, there were a lot of parameters which were given, predominantly invasive parameters. But in the current era, what we use, and most of the registries do recommend that we use non-invasive risk parameters. And you can see this has been validated over thousands and thousands of patients. And what do we use? We use WHO functional class, 6-minute walk test, BNP or NT-proBNP. Now, these are the two ones which are invasive, that is the right atrial pressure and cardiac index, and the systemic vascular and a mixed oxygen saturation. However, the most recent paper, which by Dr. Benza et al., in which they have given a non-invasive risk stratification criteria, and it's easily available and freely available on the net, in which we have all the non-invasive parameters. We don't have the right atrial pressure and the cardiac index, and even with that, we are able to predict risk stratification. Now, once I've predicted risk stratification, what does it mean? So for me, if a patient is in the high risk category, the risk of sudden cardiac death is 10% or more. If it is in the intermediate risk, it is between 5 to 10%, and if it is low risk, it is less than 5%. So if my patient is basically in the high risk category, my aim is to get a patient to either to intermediate or low risk category. So it's always, and to keep the patient in the low risk category for as long as possible, right? So, and that is what the basis of my medical management is. So for medically managing pulmonary hypertension, we have basically 3 pathways of medications. They are the prostacyclin pathways, nitric oxide pathways, and endothelin pathways. And these are all the medications which are available. However, till very recently, the prostacyclin analogs were not really available in India. So these are the medications which have been approved by US FDA. The prostacyclin analogs, such as epoprostenol and treprostinil, they are the first ones to be approved in India, approved by the US FDA. However, they are not yet available freely in India. Right. So I'll go to specific pulmonary vasodilators, maybe in short. I'm specifically stressing on calcium channel blockers because they are easily available, and if the patient is vasoreactive positive, the patient has got a lot of benefits because of that. So calcium channel blockers, they should be used in patients who have undergone vasodilator testing and has been labeled as responsive. As I said, during the right heart catheterization, we give inhaled nitric oxide, and if there is a fall in the PA pressure of at least 10 millimeters of mercury to less than 40, with increase or no change in cardiac output, we call the patient vasodilator positive. Incidence is 6 to 20%, and these are the medications which we use for inhaled for vasodilator testing. So as we are usually taught in our medical practice or medical school, that right heart cath in pulmonary hypertension is dangerous. However, we have done around 170 right heart caths in the last 5 to 7 years, and we have had only one complication. As you can see in this patient, this was a patient which was pre-nitric oxide, and post-nitric oxide, the patient developed pulmonary edema. So this patient, when we went back and saw, he actually had a disease which is called as pulmonary veno-occlusive disease. And that's the only complication we have had till now. But if the patient is calcium channel responsive to vasodilator testing, as you can see over here, the prognosis is much, much better as compared to the patient who has got who is not responsive to vasodilator testing. So that is the importance of doing a right heart cath and a vasodilator testing in every patient of pulmonary hypertension. So as I said, we have around 472 patients, out of which cardiac cath was done in 176 patients with idiopathic pulmonary hypertension, and just one of them had serious side effect like this pulmonary edema, which we mentioned before. And most of the patients were started on calcium channel blockers with a median follow-up of 3 years. All of them are in function class 2. Next, we go to upfront combination therapy or sequential combination therapy. Now, if we are not using calcium channel blockers, we are left with basically 3 groups of medications. That is the nitric oxide pathway, that is sildenafil, tadalafil, riociguat. The endothelin receptor antagonist pathway, that is bosentan, ambrisentan, macitentan, and the prostacyclin pathway, which now Selexipag is available. But I'll show we have a little bit more experience about the medications. So as we all know, this was the first trial, which is also called as the ambition trial, which looked at the combination of ambrisentan and tadalafil, and they showed that an upfront combination therapy improved morbidity as well as mortality in patients with pulmonary arterial hypertension. So nowadays, if a patient is in moderate risk category or a high risk category, we have to straight away, or even in very, very few patients who are in mild risk category, we straight away go into upfront combination therapy with an endothelin receptor antagonist and a phosphodiesterase inhibitor. Very, very rarely, we may be giving only one medication, especially in patients who are Eisenmenger syndrome. They may require just one medication. But apart from Eisenmenger, most of our patients would have an upfront dual combination therapy. And whatever combination you use, all the combinations have shown to have improvement in the pulmonary vascular resistance, 6-minute walk test, cardiac index, everything, all the combinations. So whatever combination you use is fine, but please use a combination therapy as an upfront medical management. So what is the protocol that we follow? We do a detailed counseling regarding the nature of the disease, current disease state, treatment goals, and options available. Then we do the risk stratification, and in high-risk patients, we directly counsel for prostacyclin analogs, spot shunt, or heart-lung transplant. If you have a low or intermediate risk, we do an upfront dual combination therapy and return visits after 3 months. And if the non-invasive risk assessment is done, and if the low risk is achieved, then you continue with the same medications. If the low risk is not achieved, then it is time to add the third medication, which is the prostacyclin analogs, or a port shunt, or refer the patient for a heart-lung transplant. And this has to be rigorously followed, because if we don't do the rigorous assessment of these patients, more often than not, by the time we actually refer, it's actually may sometimes become late. So triple combination therapy, what is our experience? So we have 23 patients on inhaled iloprost, 7 patients on subcutaneous treprostinil, and 20 patients on Celexipac so far, with an average age of 3 years to 56 years. So this is our youngest patient. You can see he is using the iloprost by his own, with a follow-up period of 18 months, and has improved in functional class and has decreased in NT-proBNP, and none of them had any major side effects which made us withdraw the medications. Most of them showed improvement in the echocardiographic parameters. However, what happens is, eventually, sometimes what happens is, initially response is achieved. However, over a period of 2 to 3 to 4 years, the response slowly wanes, and at that point in time, there may be a benefit of changing the prostacyclin analogs, as you can see has happened in this patient. She's again in function class 2, and her NT-proBNP is down in thousands. So what do we do beyond medications is graded exercise and yoga, atrial septicectomy, septostomy, port shunt, and heart-lung or heart-lung transplant. I think Dr. Basha Khan will concentrate on lung-heart-lung transplant, and I will specifically be talking about atrial septicectomy, septostomy, and the port shunt. So atrial septostomy, it is a age-old intervention which was advised for pulmonary hypertension. It decompresses the right atrium, increases the LV preload, increases the cardiac output, and improves the hemodynamic symptoms. Disadvantage is desaturated blood reaches the coronaries as well as cerebral vessels, and decompression is only in diastole, and it has a very high chances of the communication becoming small over a period of time. So our own colleagues from Chennai, then they have published a paper in which they have shown that this an atrial flow regulator. If you use an atrial flow regulator, the chances of it getting small over time is less. Port shunt is an interesting concept in which there is a connection is made between the left pulmonary artery and descending aorta. It was first described in 2004. What happens is, because there is a connection, there is the RV gets decompressed both in systole as well as diastole, and the desaturated blood goes only into the lower part of the body. The upper part of the body and the coronaries get normal blood flow. It's a very interesting concept, and it eventually results in improvement in the right heart function. So we have our own experience of port shunt. So in which it was done in counseled, 52 patients were counseled, out of which 23 patients agreed for port shunt. We had 4 in-hospital deaths and 2 late deaths. Yeah, this is not working, but if you can see, there is improvement in the RV function. The interventricular septum over here is going into the left ventricle, and here it is flat. So there is improvement in the into the RV function as well as the PA pressures as well. And this is we published in Indian Heart Journal, in which we have shown that there is improvement in the RV function as assessed by echocardiogram as well as NT-proBNP, and also the symptomatic status of the patient. The survival of the patient is much better. So this green one is the one in which the port shunt was done, and the blue ones in which the patients did not undergo port shunt. However, it is not without risk. and we identified the risk criteria in our patients, and older patients with a lower right ventricular function, a lower cardiac index, and a higher right atrial pressure were poor prognostic markers for a surgical portion. So most of our data in the previous in the published patients was a surgical portion. So when we saw that, we thought that what can be done for patients, adult patients. So basically, if you see adult patients with pediatric patients do well with the portion, but what do we do for the adult patients of pulmonary hypertension? So in which we thought about doing a transcatheter portion in adults, in which we go through the femoral artery and the femoral vein, and we make a communication between the aorta and the pulmonary artery using a radiofrequency ablation catheter, and then we put a covered stent between the aorta and pulmonary artery. And we have done 2 such patients. This is first time has been successfully done in India for the first time at our institute. We have done 2 patients now who were on triple combination therapy and continue to have syncope with a very high anti-pro-BNP and suprasystemic PA pressures, and they were not willing for a lung transplant. And we have a follow-up period now of 3 and 2 months. They don't have syncope anymore, and there is improvement in the RV function. The lung and the heart-lung transplant was first described in 1981, and I will leave it to Dr. Basha Khan to talk to you about further details. To conclude, thorough evaluation of patients with pulmonary hypertension is essential prior to initiation of therapy. Patient risk stratification and individualized therapy is key to manage pulmonary hypertension, and prostacyclins or prostacyclin analogs are the need of the hour. Innovative treatment strategies like port shunts need to be considered. Thank you. And I'm sorry for the delay.
No problem, sir. Thank you so much, Dr. Prashant, for this smooth presentation. I think this was right to put set context to today's discussion. I would now request Dr. Khan to please share his screen and talk about transplant and PH. And then post that, we'll take questions.
Sure. Thanks, Darshika. Appreciate this.
Yeah.
Yeah. Thank you. And Prashant gave a detailed talk, and as usual, quite elaborate, and shares his experience also. So I'm going to discuss about transplant option in PAH. We all know that pulmonary hypertension is a complex disease, and in few selected patients, transplant is a valuable treatment option. And the first point I would like to stress is only if patients are diagnosed in appropriate manner and they are on appropriate treatment, and if they are failing on that, then transplant is a treatment option. So I'm going to discuss in brief, although Prashant has discussed, because I was not sure which target population we are going to address. So there will be some slides about approach to pulmonary hypertension, risk assessment. As usual, it is extremely important to decide the treatment option. And since we are in 2022, it's a shared decision making between the patient and the treating physician. And we also have to understand the treatment option in the Indian context. Whatever the treatment guidelines from 6th World Health Pulmonary Hypertension Symposium, transplant, these are made for Western population. We have to, we can't compare apple and oranges. Sometimes we have to tweak, and I'm pretty sure in next 10 years, we will have much more Indian data so that we can have our Indian guidelines. So we all know that. So I'm going to discuss about pulmonary hypertension in clinical classification, group 1 pulmonary hypertension patients. We all know that there are 5 groups of pulmonary hypertension So this is the clinical classification. So class 1 is PAH, which includes idiopathic, heritable, and the one which is associated with connective tissue disease. And one important contributor to this group in Indian context is congenital heart diseases leading to Eisenmenger syndrome. And another important component of this group is pulmonary veno-occlusive disease. Then group 2 is due to left heart disease, group 3 is lung diseases, and group 4 is the CTEPH. We are the largest center for CTEPH, and we have now registry of around 800 patients. You can see this slide clearly depicts that the one in blue color group clinical classification group 1 and group 4, the FDA approved therapies are only to be used in this group. If we use in group 3, group 5 or group 2, I think we are not going to help them, and moreover, the data shows that these therapies are more harmful. So that was the clinical classification, and Prashant has already elucidated about the hemodynamic classification also. So I'm not going to delve in this in detail, but you have to understand that pulmonary hypertension has three important components. When we say the hemodynamic definition, one is the mean pulmonary artery pressure. Your wedge pressure should be less than 15 and PVR of more than 3. Sometimes if in specific cases like liver disease, you will see high cardiac output, or when you have left heart disease, all these can lead to high PA pressures, but these are not pre-capillary pulmonary hypertension. As usual, whenever these patients come to us with non-specific symptoms and pressure, there are two important things which we have to address when we are seeing this patient first time to our clinic. First is, what is the probability of pulmonary hypertension, whether they have high or intermediate or low. And the second, after you establish that, is risk stratification. So there are few, I think in Indian context, each and every patient goes on echo whenever we have a suspicion of pulmonary hypertension. And there are, we all know that Bernoulli's equation is used in calculating the TR jet, but there are many other things besides TR jet which should be carefully looked before we label a patient having high probability of pulmonary hypertension. So as you can see this on this slide, this is the clearly states that the most important thing is looking at the TR jet velocity, and once your TR jet velocity is more than 3.4, it is a high probability of PH. But if it is you're not getting a good TR signal, or your TR jet velocity is in between 2.8 or 3.4, you have to look for other echocardiographic sign. So either you can look at right ventricle, you can look at pulmonary artery and IVC. So you can, if you're looking at right ventricle, you can look at TAPC, you can look at the diameter of right and left ventricle, whether the septum is going towards the left side. If you're looking at the pulmonary artery, you can use pulmonary artery acceleration time. You can look at the pulmonary artery diameter and IVC collapsibility also. So you have to keep in context all these things before we label somebody as pulmonary hypertension. And this is the most important slide from a transplant pulmonologist perspective. What is when I see a patient, what are his risks? So we classify, Prashant has said that we classify them into low risk, intermediate, and high risk. And this is the REVEAL score which we use commonly. It has clinical criteria, it has imaging criteria, it has hemodynamic and CPET. So there are few things like clinical criteria and imaging like echo and CMR. We can use it quite often. It is easily reproducible. but we can't put each and every time patient for right heart cath. CPET is also utilized in our center, specifically if when we are choosing these patients for surgery to decide also. So it's also important vital tool, provided it is done in a careful environment. One of the things which I would like to stress is that in this risk assessment, there's no mention of pulmonary arterial hypertension. And often we get referral that patient's PA pressure is 140 by 90, by 60 with map of 100. And we try to equate it with the systolic blood pressure also. But you can see in this risk stratification, there's no mention of pulmonary arterial pressure. But it has importance, but not in risk assessment. And this is, if we are not able to use in Indian context, I think this is much more useful to use the Reveal Light 2 criteria and see where we are, patient is there. And if it is low risk or intermediate, try to optimize the medical management. And if it's high risk, have an open discussion with the patient if he's on optimal medical management and if he's still failing. When I start, it's a complex disease, and most of us are busy in our OPD, and we look only a few parameters like functional capacity or hemodynamics. But when patient is presenting to my OPD, they have much more other concerns. They have, excuse me, there's a fear about right heart catheterization, financial impact. There is also many of these patients come to our OPD on oxygen, and they have to plan for at least 2-3 days how to arrange that. There is a fear of loss of employment, education, and social life. So I think that we have to consider all these things when we are making a shared decision making. And as a physician, we are sometimes look at the tip of iceberg while missing much of the broader aspects from the patient side. This treatment algorithm, as we know that, so once we have established the diagnosis, patient goes for vasoreactive testing, which is only approved for IPH or hereditary or drug-induced. And if it is sensitive, they go on calcium channel blocker. And if they are non-reactive, they go on lower intermediate risk. They go on pH, sorry, oral pH medicines. And if they are on high risk, you can clearly see that the first approved therapy is IV prostacyclin, and unfortunately, it's not available. A couple of our patients are using either inhaled iloprost or subcutaneous treprostinil, and their condition has stabilized. So if they're high risk and disease is progressive in nature, then transplant becomes a viable treatment option. This I would like you to understand this slide in according to Indian context. We all know that. So I have divided this slide into two parts. So one is the route of the administration of the drug, and second is the molecular target pathway. Prashant has already described the molecular target pathway. The other thing which we have to look is there are some drugs which are available as oral. We have inhaled form, we have subcutaneous form, and intravenous. And this horizontal box, these are the medicine which are available in India. So most of the time we are using, when patient is having high risk, we try to stabilize them on triple pH therapies. And in some few selected cases, we are using inhaled iloprost or treprostinil. Unfortunately, this is lagging. And I would like, if it gets available, all these patients should be on IV prostacyclin before they get referred for transplant. many of times these patients present to us in right heart failure. So we have to stabilize them before taking in for consideration. For why it is important to recognize the heart failure, because once they reach the ICU, the mortality is more than 50%. And we have seen, and literature also supports that around 30 to 40%, 30 to 50% of these patients decompensate either due to infection, arrhythmias, or pulmonary embolism. So whenever these patients are in our ICU, we try to find out what is the reason of decompensation, and then also we address the failure by optimizing heart failure. So we try to reduce the preload by using diuretics, or sometimes you have to do hemofiltration. We try to utilize pH medications to reduce the RV afterload. Sometimes we have to use cardiac optimize inotropic support by using dobutamine and milrinone. Each transplant or pH center has its own preference. I don't see any major data to say that dobutamine and is there a major difference between these two. And last but not least, sometimes they are in hypotension or shock, then you have to use vasopressors like norepinephrine or vasopressin. And if they are not showing good response, and if there is a realistic perspective for recovery, then we can offer them transplant. And if it's not possible, then we continue supportive care therapy. And sometimes we use ECMO and ECLS support as a bridge for transplant. So mechanical circulatory support means ECMO support predominantly. So it can be used as a bridging therapy when sometimes patient presents in frank right heart failure without established diagnosis or treatment plan. So we can use ECMO as a bridge to transplant. Predominantly, VA ECMO is recommended for patients for when they present with right heart failure. In some selected cases, if they have developed pneumonia or infection, VV ECMO can be also utilized. And ECMO is also utilized in post-operative period in PH patients who undergo transplant. One unique configuration of use of ECLS is PA to LA Nova lung use. Unfortunately, it's not available in India at present. It also helps to decompress the right ventricle, and but patient needs to go to theater, and it's a central cannulation. So when I see a patient for transplant evaluation, the first and foremost is to make sure that it's a right diagnosis. And then I have to understand the nature and progression of the natural history of the disease. We also have to assess the response to therapy, expected waitlist time, which differs across different states, and also the transplant outcome versus expected survival of medical therapy. So to understand the natural history of the disease is utmost important when we are having a discussion about transplant. This is a busy slide from Aspire registry. They collected the data over a period of 9 years from UK, and they evaluated treatment naive population, and they assessed around 1,500 population. So you can see the top right-hand box shows group 1 pulmonary hypertension without any treatment. You can see that the Eisenmenger patient population have much more long-term survival because they have a shunt as compared to PAH, and the patients with systemic sclerosis patient have the worst outcome. So when I'm seeing these patient population, I try to understand and fit them in which particular group they are belonging to, so that right decision can be taken. Another slide similar to previous one, it is from ERJ. It also includes, it tries to compare the IPH with connective tissue with CTEPH, pulmonary, portopulmonary hypertension and PVOD. As you can see that although the PVOD belongs to group 1, there is no approved therapy for that, and PVOD patients have the worst prognosis, while IPH patients live longer. And CTEPH patient, if they don't get operation, then their outcome is also a little bit worse as compared to IPH patients. So what are the referral criteria? So there are two important terms which we have to understand, referral and listing. And referral means when I see the patient first time, and it takes at least 5 to 6 months to establish a rapport with the patient and before they get listed. So referral criteria means, so what are the criteria? So we can use our reveal risk score, and if the score is more than 7 on appropriate medical therapy, then it becomes a criteria for referral. And there are some specific condition, as I showed in previous slide, like if you diagnose somebody with PVOD or PCH, or sometimes we see large giant pulmonary artery aneurysm, which have a high incidence of dissection and rupture. These patients should be referred to the center earlier, even if they are having recurrent hemoptysis, they should be referred earlier. And when, so what's the criteria for listing? So listing criteria means reveal score of more than 10 and failing on all medical management, worsening hypoxia, as I suggested, especially in PVOD and PCH patients, and life-threatening hemoptysis. These are the criteria which should be utilized when we are referring. As we know that there are only 3 and 4 designated transplant centers in India, and they are in south part of the country in Hyderabad, Bangalore, and Chennai. And many of these patients, they are in northern part of the country or eastern part. So it is of utmost important that treating physician should go over these slides to decide which patient needs to be evaluated in expert PH center or transplant center. Or this is another way to summarize that there are different phases of pulmonary hypertension. So if you are in low risk, you are compensated, you have good cardiac output, and your right atrial pressure is also quite low, then you continue medical management. But sometimes either the disease is progressive in nature, or they get some infection or arrhythmias, they suddenly, then there's a takeover, their cardiac output drops, their right atrial pressure increases. So these are the time when you have to refer them or consider for listing. And another important point which I would like to stress is on this slide is, if you use a traditional method of echo, when patient is failing, his PA pressure starts dropping, while clinically there is a worsening. So if you use just PA echo, PA pressures to understand the disease, you think that patient is improving, but you have to look in more details. He will be having elevated right atrial pressures and all those things. So just don't look at echo parameters, because in the end stage, this is not a good parameter to look for. So the most difficult thing in decision making is whether a patient is going to live and a meaningful life with transplant, or whether we are going to harm. This is the most important and challenging discussion. And we also have to discuss the quality of life. we are changing the patient from acute to chronic condition, but it is also so it offers a meaningful life, but in selected patients. But you have to understand that patient is going to be lifelong on transplant medicines. They need a frequent follow-ups, and they have to deal with. We are going to give them in next couple of years transplant-related issues like renal dysfunction, rejection, sometimes diabetes, and all those things. So this is the slide from ISHLT. There are some absolute contraindication and some are relative contraindication. Absolute contraindication means transplant is too high risk and you don't anticipate a successful transplant outcome. And they also suggest that, advocate that we should not offer transplant to these patients except under very exceptional cases only. So what are the absolute contraindications? Like patient not willing for transplant or acceptance for transplant. If patient is an ECMO, it's a relative contraindication. Patient having active HIV, having active malignancy, active liver failure. These are some of the absolute contraindication, or having active TB. There's a whole list of these slides. You can go over and take the call accordingly. This is the most important slide of the presentation. This slide shows the data from ISHLT about the transplant outcome, and it collects the data from 1992 from 2017, and you can see that IPH patients' median survival is more than 7. So that's why when we think that our patient is not going to survive more than 2 years in spite of optimized medical management, it is prudent to consider transplant because it makes a significant improvement in their quality of life as well as in their survival. And another thing which I would like you to stress is that if you see the number of years, at 10 years also with improvement in medication and care, many patients are around 40 to 50% of the patients are now crossing the 10-year boundary, which is quite a reasonable benchmark. And not even at 10 years. At 20 years, you can see that around 25% of patients are alive at 20 years. So it's in a careful selected patients, it's a viable treatment option. We also get a call about advantages of double lung versus heart lung transplant. It has its own merits and advantages and disadvantages. In group 1 PH, if you don't have significant RV dysfunction, then the ideal transplant is double lung transplant. It is less complex operative dissection, as well as the median survival of double lung transplant is 7.1, while heart lung is reserved only when you have concomitant severe or RV-LV dysfunction. But you have to understand that you are going to utilize 2 organs, and sometimes it can increase your wait list time to even 1 year or 2 years. In addition, there is a scarcity of organs. And last but not least, the heart lung transplant survival is lesser as compared to double lung with median survival of 6.5. And this is also from ISHLT. You can, over the last 20 years, you can see that when in early 90s, most of the program, when they started their transplant unit, they did a lot of heart-lung transplant, but gradually over the year, the transplant number is coming down and hardly less than 40, 50 transplants are done across the world. When I was in Toronto over a 2-year period, they did only 2 heart-lung transplants. I think in carefully selected patient, and a good post-operative care, we can manage most of these patients uh, with double lung transplant. There will be specific issues, but with use of ECMO and due diligence, we can tide over the ICU storm. And normally we see these storm of post-operative care in first 5 days. So it's also matters the experience of the team. If you tide over those first 1 or 2 months, PH patients have quite good outcome. And I'm going to share these two cases which we saw recently. You can see 39-year-old lady who was diagnosed to have large ASD in 2008, and at that time her PVR was around 10, and she was offered medical management and not to close the shunt. And I think it was right decision. Somehow she was not compliant with her medicines, and 2 months back she deteriorated. You can see that and the reason for deterioration was acute PE. You can see a large pleural effusion. So we started optimizing her medical management. Her right heart cath data showed RA pressure of 12 with systolic PSP of 78 and wedge of 12 and cardiac index of 2.3. So since she was not on medical management in terms of pH therapy as well as anticoagulation, we informed her and that let's stabilize her condition, and we are going to assess her in 6 weeks time where she is heading. If her hypoxemia persists and if she still remains according to revealed risk score more than 10, then we are going to offer her transplant. So she is a case of ASD with Eisenmenger with in situ thrombosis. Another interesting patient which I saw, 33-year-old gentleman who was referred from Calcutta, that he's getting worse in spite of taking dual pH therapy, and his pulmonary arteries were quite enlarged. But the thing which surprised me, you can see these interlobular septal thickening and some ground glass opacities, which is rarely seen in group 1. We did cath at the same time, which showed normal wedge pressure and high RA pressures and low cardiac index. So this was quite suggestive of PVOD. So this gentleman was put on imatinib and he got immediately listed for transplant, because we know that PVOD patients have worse prognosis. So we have to individualize the treatment accordingly and then take the call. So my take-home message is the foremost important is to establish the right diagnosis. I have received portopulmonary hypertension for transplant, while what they needed was correction of their portal pressure, not pulmonary pressure. Then second most important thing is the risk stratification. And in some carefully selected patients, in spite of optimal medical management, if they are failing, then a transplant should be offered. Thank you.
Thank you so much, Dr. Khan. And that was definitely, I think, a very, very intense discussion. We have 2 questions, because I think we received a lot of questions, but I think majorly have been covered through yours and Dr. Bobhate's discussion here. So could we take these 2 questions? So my first question is from Dr. Halid, who's a general practitioner from Dubai. He says, as we face rejection in renal transplant, is there any rejection in lung transplants as well? If so, how to overcome this issue?
So this is the major problem in all transplants. So it's not uniquely related to kidney. Lung has a huge burden of lymphocytes. So we see same immunological challenges what we see in kidney. So we have acute rejection, we have chronic rejection, and the histopathology is same. We see intense inflammation around the vessels, and the treatment is also same. While another thing I would like to stress is, although we have treatment options for acute rejection, all solid organ transplant, including kidney, we don't have so much optimal medical therapy for chronic rejection. So yes, it is the correct problem which all solid organ transplant face. Liver transplant has less. That's a unique gift. But otherwise, heart, lungs, kidney, same immunological risk and challenges.
Dr. Prashant, you want to add something to that? Are we good to go?
No, we are good to go. I think Dr. Pasha has covered.
Okay. My second question is from Dr. Agrawal. So I think this question we can give to Dr. Prashant. So this question is about, is the diagnosis based about pulmonary hypertension? Is the diagnosis based on pulmonary artery diameters alone or on PA pressure or both? And what is the criteria to start treatment?
So the diagnosis is based on the PA pressure alone. It is not based on the PA diameter. PA diameter is just again on a CT scan. If you see the PA or on echocardiogram, you see the PA diameter is high. Then we have to go and see what the PA pressures are. Firstly by echocardiogram, and then by the gold standard is by right heart cath. And a patient of pulmonary hypertension. So we need to classify into which group of pulmonary hypertension is falling. As sir has already said, that the therapy is only for group 1 pulmonary hypertension and select cases of group 4 pulmonary hypertension, that is thromboembolic PH. So either the patient is in group 1, that is pulmonary arterial hypertension, or group 4, that is thromboembolic pulmonary hypertension. The therapy is reserved only for these patients, and it benefits most of these patients. Group 2 PH, that is left heart disease, group 3, that is lung disease, and other group that is miscellaneous, they may not benefit, or actually in group 2 or group 3, it may harm the patients. So patients with group 1 and group 4, select cases of group 4. Group 4 is primarily a surgical problem, where we have, where I shared a case that endarterectomy has to be done if it is feasible, and if it is not feasible, then medical management.
I would like to add. Yeah, thanks for giving me the opportunity. We have only one registry from India, from Kerala, and I think it matches the Western world. Around 60% of the patients who are diagnosed PH is the left heart disease. And in that, around 20 were from pulmonary, around 10%. But it was all echo-based registry. So still, the left heart disease is the predominant component, which we have to. And as the age of the patient increases and as the comorbidities increases, you're thinking more about left heart disease. And your metabolic symptoms, little bit obese, diabetes, crossing age of 60, all those parameters.
Okay. We do not have any more questions here. I think majority of them have been covered in the talk. But I would definitely request Dr. Khan and also Dr. Prashant to give me some takeaway home message for the audience, especially the budding surgeons that are watching and want to take. We also have students in the panel. So if they want to take up, to study more about pulmonary hypertension in detail. So if any words from Dr. Khan, first you.
Always, as I said, there are two things. One is the clinical classification. Many times our students get confused between clinical classification and hemodynamic classification. These two are totally different, and you have to find a path when you are treating your patient. That's one thing. And most important thing, 60% of the patient have left heart disease. Don't cause harm. If we cannot treat patients, don't cause harm. So left heart disease is the major crux of the problem, and try to dig more. And last but not least, CTEF gets missed, and these days we are going more on echo, and We are not looking at clinical examinations. If you do a thorough clinical examination, it will give you some subtle signs and history taking. There are patients, I'm pretty sure, Prashant, and we see Abernathy syndrome or portopulmonary hypertension miss for many, many years.
Thank you so much. I think there was a question also about asking about if ECMO is the right and the only, echocardiogram is a good way to diagnose pulmonary hypertension. But I think Dr. Prashant during his talk did mention about it, so we did not take that up. So any words from you, Dr. Prashant?
So yeah, as I completely agree with sir. First and foremost in pulmonary hypertension is try to dig deep and try to find the etiology. If you can find the etiology, treating the etiology is going to give you more results. And the second most important is the risk stratification for management of pulmonary arterial, that is group 1 PH. So these are the two crux or cornerstones of managing pulmonary hypertension. A good etiological workup, number one, and second is after that is risk stratification, and modifying a therapy based on risk stratification is what is going to give you results and what is going to benefit your patients the most in the follow-up.
Okay. Yeah. Thank you so much. And then this brings us to the end of the session. So thank you so much to both the doctors for being present here and helping us spread awareness and have this clinically rich discussion about pulmonary hypertension, especially in transplant. So we hope our audience would definitely have so much to learn from this. And if we receive any more questions, we would love to share them with you. And dear audience, thank you so much for joining in today. Please stay tuned for such clinical sessions exclusively on Dr. Thank you so much, Dr. Khan.
And we would like to have the feedback so that we can improve and we can bring new topics and which students or community faces challenges. We are always open.
Yeah. Thank you so much. Do drop in your comments. Thank you.
Bye.